The temperature was 101 degree Fahrenheit, mild tachycardia with 108 beats per minute, and SpO2 was 82% on room air. The patient's respiratory rate was not as high as there was fall in SpO2, which indicates to type 1 respiratory failure. She suffered with these complaints for a period of about 5 to 7 days, after which she approached her family physician, who ordered basic investigations and also advised admission. The patient was admitted and further confirmatory investigations were advised after the basic primary treatment was initiated. The blood and serum investigations were as follows. HB was around 10.8, total count was 9,800, towards the higher end but within the normal range. Neutrophilic predominance in the differential count and platelet count was within normal limits. There was raised CRP and SGBT levels. The chest X-ray which was carried out showed right lower zone infiltrates with bilateral reticulations, as we can see. Similar chest X-rays can be seen in I think all of your OPDs, and the differentials which we can calculate from the following investigations would be either community acquired pneumonia or viral pneumonia. Maybe tuberculosis also, but less likely. It is lower zone, so less likely, and the symptoms are of shorter duration. The confirmatory investigations for the suspected diagnosis was swab for RT-PCR, which was collected for COVID-19, which was negative, and H1N1, which turned out to be positive. The ideal time for swab collection is during the initial 5 days of the symptomatic period. The patient, whoever is symptomatic, is infective also when they prior to the onset of symptoms and up to the 7 days till the symptom onset. So that is the first 5 days is the best period to collect the swab, which turns out to be positive in most of the cases. Investigations which can also be done in such a case is sputum for AFB, sputum for routine and microscopy examination, and for culture and antibiotic sensitivity. Also, one can go for HRCT thorax. Since H1N1 was positive, the treatment we all know is oseltamivir. For adults, the dose is this is therapeutic dose 75 mg capsule twice a day for 5 days. And children at the age of 12 months or older only, after 1 year of age, 15 kg or less, 60 mg per day. And the following doses, as you can see. One thing to note, more than 40 kg, the dose is 150 mg per day in 2 divided doses. It is much more than the adult dose. Brief note about oseltamivir. It is an inhibitor of the influenza neuraminidase enzyme. We all know the structure of H1N1. The N1 particle is there, which is inhibited by oseltamivir, interfering with host cell release of the complete viral particles, and is used as a therapy and prophylaxis against influenza A and B. So basically, when the virus is infecting any cell, it is replicating inside that cell, and then that particular cell dies, virus particles are released into the body, which spread to other cells. So this particular drug is inhibiting the neuraminidase enzyme, which is responsible for the release of the viral particles from the infected cell. So this can slow down the progress of the disease in the infected person. Efficacy has been demonstrated when the treatment is initiated within the 2 days of the first onset of symptoms, and it is also indicated for prophylaxis of influenza in patients 1 year and older. The other supportive treatment given to this patient was oxygen inhalation, keeping the target SpO2 at 90%. Again, one thing to be noted is oxygenation is required when there is hypoxia, but at the same time it should not be over-oxygenated, as oxygen in itself is a drug, and like any drug, it will have its side effects. So the target SpO2 should be maintained at 90%, and titration of the supply of oxygen should be done accordingly. So a brief note I have mentioned here, nasal prongs maximum oxygen delivery can be up to 6 liters per minute. So if the patient is having requirement above 6 liters, kindly do not use nasal prongs, as the diameter of the will not be sufficient enough to provide that amount. It will be wastage of the oxygen supply. The face mask oxygen delivery can be up to 10 liter, and NRBM would be up to 15 liter per minute. Over here also, one must ensure that the bag is full. We all have seen during COVID that all these things were mentioned. And if the patient is not maintaining after 15 liter per minute, then would require BiPAP or invasive ventilation. The injectable steroids can be started as it is viral pneumonia, and it would help in reducing the inflammation in the lungs. Methylprednisolone started with 1 to 2 mg per kg to be tapered as per clinical improvement. And such patients are also usually seen in the practice are diabetic patients. because they are more prone to infections and hence viral pneumonias as well. So the dose of the steroid must be judiciously titrated, keeping in mind the diabetic blood sugar levels. The broad spectrum injectable antibiotics to prevent secondary bacterial infection and nebulization for the airway. Over here I have mentioned two combinations. One is SABA plus SAMA, that is short-acting beta agonist plus short-acting muscarinic antagonist, which is commonly known as duolin or Combimist L, combined with ICS as budesonide. So another what we can use is LABA plus ICS, as long-acting beta agonist is also having faster onset of action. So it is comparable to SABA action and it will remain for longer number of hours. So Foracort with SAMA, that is ipratropium. So that combination can also be used. Then the improvement in the patient after 5 days of treatment can be seen in the WBC levels. There is a slight rise which can be attributed to the use of steroids. As when we are introducing injectable steroids, we might expect a slight raise in counts. So it may not, please never get misguided as it was rise in infection, if it is a slight rise. Differential count has increased in neutrophilic predominance and the platelet count is within normal limits. SGBT has reduced and CRP has also reduced to significant amounts. The brief about swine flu. It is a highly contagious acute respiratory disease of the pigs which was caused by the several strains of influenza A. This was H1N1. In humans, the symptoms of swine flu are similar to those of influenza, which are chills, fever, sore throat, muscle pains, severe headache, coughing, weakness, and general discomfort. We all have seen this clinical picture some or the other time in our OPD. The microbiology, a bit into the microbiology, this virus is having type A, B and C enveloped RNA virus. It possesses two main surface antigens, H1 and N1. Transmission is through the inhalation or ingestion of droplets and it is not by the consumption of cooked pork. Pathophysiology is the viral neuraminidase activity is important, like I mentioned with oseltamivir. Viral entry into the uninfected cells is also due to the N1 particle, the release of recently formed virus particles and the further spread is all due to N1 particle. Hence we have the drug against that. How the virus works: it enters through the mouth or nose and it moves through the airways into the lungs. It attacks the respiratory tract and it inside the cell until the cell dies, releasing more of the virus into the body. Now the patient's immune system starts to kill the virus, but if there is a large number of cells which are destroyed in the lungs, the patient will not survive. Radiological features on HRCT. The following features can be found: ground glass opacities, interstitial thickening, centrilobular nodules, and consolidation with air bronchograms. Over here we can see this is similar to what we must be seeing during COVID. So as it is a viral pneumonia, there is a similar picture. The ground glass opacity is marked here with the arrow. Then there is the nodules which are marked with empty arrows, centrilobular nodules between the lobules, and then there is the consolidation which is marked here with the triangular arrows. So these are the features which would be seen on the HRCT. If such features are seen, it is indicative of viral pneumonia. Flu prevention tips, basic prevention practices: washing the hands, keeping the sanitizer close, not touching the face, especially the nose and the eyes, and the smile, and this is just eating right, exercise, and staying home in isolation. Two types of influenza vaccines which are available: the trivalent, which is the killed vaccine, also known as TIV, and it is also providing protection against avian flu, H3N2, and live attenuated influenza vaccine is the nasal spray. The TIV works through the bloodstream and the LAIV works through the same stream, but it is weak virus, which is live but weak, cannot cause the disease. For further reading, for the consultants who are in intensive care, a prediction model evolved for high morbidity using clinical laboratory profile of patients hospitalized for influenza, the CRACS index. It prolonged hospitalization of more than 6 days, ICU admission of more than 48 hours, ventilator use were combined as composite morbidity outcome, for which prediction model was evolved. It was found to have sensitivity and specificity of about 80%. TRAC stands for elevated serum creatinine, respiratory failure, AG reversal, and abnormal chest X-ray. The further details on this are available in the European Respiratory Journal September 2021 edition, if in case anyone is interested in knowing about it. Thank you. Any questions?
Without any investigation, at a GP level, prime of showing case effects are always.
Since both are influenza variants, so it would have similar features. The clinical features are almost same. The symptom, the onset, even the duration of progression is also same. And hypoxia is also found in both the diseases. So, and the treatment also stands to be this almost similar, except that oseltamivir is active against swine flu. But other supportive treatment remains the same. Yes. So, any viral infection, the steroid is the best line of treatment that can be used. So, because it causes decrease in inflammation and also helps in the airway, which is involved in the respiratory tract. So, the bronchodilator effect and the airway inflammation is reduced significantly with steroid use. So, per se, in my experience, whenever we have treated respiratory infections which are non-bacterial, once we have ruled out that it is not bacterial pneumonia, then steroid is the most reliable line of treatment. Antivirals, though being the supportive treatment, but steroids are always used. So over here we are discussing about viral pneumonia. So in that definitely steroid is used. Apart from that, rheumatoid and other conditions also steroid are used.
In viral like patient is suffering from HIV. Then what is the role of steroid?
Sir, HIV there is antiretroviral therapy which is used. There is no role of steroid. Like this is particularly the lung infection which we are talking about, where the steroids will be helpful.
The mechanism is like that: antibody, which body produces against virus, also damaging our body as well. It is not the virus which is damaging the lung.
Inflammation is damaging the body.
Steroids
also are being used for
HIV secondary effect. It is a different mechanism. What HIV does? HIV destroys the CD4 cell of the body. CD4 is what? Our plain word police of our body. Whenever any organism will enter our body, CD4 will take care of that organism. HIV virus directly destroys CD4. It does not do anything other than destroying it. That's why patient of HIV used to have a fungal infection and tuberculosis and brain fungal. Antiviral drug directly destroyed HIV virus only.
It inhibits the replication of the virus itself. So HIV. Ma'am, I will get back to you. हाँ, अभी जितना मैं मटेरियल देखा उसमें सब oseltamivir was only mentioned.
Is nasal vaccine available?
Yes, sir. It has been mentioned in the literature, but locally available or not, I am not.
Locally only injectable is available.
हाँ.
What is the schedule?
Sir, a single dose is given, which is active against the immunity is remaining for around 1 year. Like in flu act, which we have.
Taking vaccine.
How
many days will one have protection?
About 1 year, sir.
If I take vaccine today, after how many days I will have a
antibodies are produced which after how much?
I'm not sure about it.
Is to be taken or which population will take vaccine? Vaccine is recommended for which population?
There is the high risk population, which for this is usually the respiratory comorbid conditions like COPD or interstitial lung disease, which have poor innate immunity of the lung. and during the flu season they are more predisposing to infection. Even severely diabetic or immunocompromised patients may be recommended. Like in our practice, what we usually used to do is we have patients who are coming in follow-up in every season with exacerbation of the respiratory disease, and they are landing up with swine flu or other pneumonias. So we are recommending Pneumovac, Influvac, and other vaccines. It remains the same for this disease as well.
How often is the co-infection with COVID-19?
Of swine flu?
Yes, swine flu and COVID-19. I saw one.
Yes, sir, but the studies for this have not been found.
Usually people, what my observation, I'm anesthetist, but only in our hospital I observe, if the patient has become COVID positive, then no other tests are done. Similarly, if swine flu positive, no other test will be done for that. So other things will be overlooked.
Prejudiced practice and
Yes.
harm lot of patients. COVID only
But
COVID.
it will overburden the medical person also.
Treatment में Allah. We have started doing so. Yes, recently we have operated one organized patient. So in local and corporate hospital we are getting them. And I'm still yet to see both.
I saw one.
When do you start steroid? Not in all patients you will start.
Yes, ma'am, when there is hypoxia, then severe respiratory damage, then depending on the CT picture, to overcome that inflammation is what steroid is required for. Otherwise, OPD patient who are coming positive need not be given steroid.
Home isolation patient and not.
If it is maintaining above 90% on room air and not worsening, the disease is being the body itself will resolve with oseltamivir and other support.
Even if saturation is maintained above 90, but patient is comorbid.
That will also depend on whether the patient is diabetic and, like I mentioned, the radiological picture. If there is significant lesions which we expect not to resolve with only oseltamivir, then steroid, even oral steroids can be started at home.
I have studied in physiology. The first is an alarm of increasing fluid level in our body. If fluid level increases in our body, we get thirst. It means we need water. Then we drink it at a level balance. Now, if we don't feel any thirst, it really means that we don't need any further fluid. And then also we advise take.
Sir, for that I would say that since it is pneumonia, there is even in the treatment that we carry out in indoor patient, there is certain amount of, for even bacterial pneumonia, IV fluids are recommended up to 1 to 1.5 liter per day. So that is because to overcome the fluid loss which is through the lungs. Like in the pneumonia, there is a collection of fluid in the interstitium as well as the alveoli. So that is the extra fluid requirement of the body. And on top of that, the viral particles which are also being released and the physiology which is altered, the fluid will definitely help. Like the platelet count which is reduced. And
during active infection, it is not necessary that patient will feel thirsty. Because patient's mind will be diverted towards his field life.
May go for AKI to certain extent. Yeah, you need to see output, you need to see intake, everything you need to see.
Output, not only urine output, you should see the
Insensible
insensible loss
loss.
to
Sweating.
airway and to skin, and if there is any bone.
On an average, it is calculated as 500 ml insensible losses. So extra.
3 to 5 ml per kg per hour we calculate as an anesthetist. Input output के लिए
Thank you, Dr. Yasir. હવે હાજરીમાં આપણી સીએમના પાર્ટનર ક્યોર ફાર્મા છે. આપણી વચ્ચે ડૉક્ટર હનીફ ખત્રી છે અને ડૉક્ટર ઉસ્માન ગની ખત્રી છે. હું બંનેને રિક્વેસ્ટ કરીશ ટુ કમ ફોરવર્ડ. ગની સાહેબ બધા એમને ઓળખે છે. સિન્સ લાસ્ટ 22 યર બોડેલિંગમાં સુખી હોસ્પિટલ છે. હોલ સર. તો હવે હું બી હોસ્ટ છું, સાહેબ બી હોસ્ટ છે. હવે ફેલિસિટેશન માટે હું આની પહેને માઇક આપું છું.
Hello. First of all, I request Mr. Chirag to come with the bouquet and felicitate the Mr. Dr. Himanshu sir. Dr. Gani will hand over bouquet to Mr. Himanshu sir. Thank you sir. Thank you for being here. I would also request Mr. Chirag to Dr. Bankim Shah sir, please be here. I would request Dr. Mohammad Hussain sir to hand over the bouquet to Mr. Dr. Bankim sir. Thank you very much sir for being here and participate with us. Thank you very much sir. Also, I would request Mr. Chirag to facilitate Mr. Mohammad Hussain sir. Please, Dr. Usman Gani Khatri sir, facilitating him. Thank you sir for giving us opportunity for this fantastic evening. Thank you Dr. Mohammad Hussain sir and BMDA to give us the opportunity for such a fantastic evening and CME. I would also request Mr. Chirag to hand over bouquet to Dr. Hussain sir. He will facilitate Dr. Usman Gani for being here. He is also a co-owner of Cure Pharma. Dr. Usman Gani sir and Mohammad Hussain sir, both are our, I can't say legend, but they are practicing things and helps our community and the whole Also, I will request Dr. Hussain sir to felicitate Dr. Nasimul. Okay, Soeb sir, please come here. He'll give handover the memento to the Dr. Merchant sir. Thank you very much sir to give us a fantastic lecture on H1N1. Mr. Bala sir, please welcome here. Doctor sir, or Dr. Arif sir, please also be here. Please come forward. You are the core and center of the BMDA while you are sitting backside. And Dr. Arif sir will hand over moment to the Jilani sir. Please give applause to her. Thank you very much sir for being here. Also I request Dr. Pala sir to come forward.
पाला साहब डॉक्टर हनीफ खत्री आपसे पूछे. आप आए बाहर आए.
Uh, Generally, I don't listen to CMEs because I'm old enough to understand what is going on in my branch research. But I don't want to see here and there. Our focus is just a man and mental illness. Couple of months back, I had a very bad injury. I fractured my backbone, precisely D11. Dr. Nasimul Jilani, I don't know many of you knows him or not, but I know him very well. He treated me, and he treated me so well that I'm in front of you. I was on a bed rest for almost 3 months, and as a man, you get an opportunity to take his services. As and when you get an opportunity to refer a patient to an orthopedic doctor, I suggest, I request, and there is no other word for me, that I would say that you should take his services, and very honest, very reliable, very sincere doctor, and at the same time, the only problem with him is he's sitting in one of the very local area. So in front of all of you, I'm just requesting Dr. Nasimul to come to the main road and see how things are, and then the sky is the limit for him. Jazakallah khair, shukriya, assalamu alaikum.
Shukriya, jazakallah. Please. Also, I am briefing my Cure Pharma company. In short, we have started before 10 to 12. Thank you, sir. Thank you very much. Be seated. We have started company before almost 10 years. We are now concreting our subject clearly. And we have started with the 7 products. Now we have reached up. It is almost now 70 products with us. Earlier we started with the general products. Now all the specialties we have covered, especially the ortho basket, cardiac basket, and diabetic basket. And we are expecting better support from you. Thank you very much.
We have Dr. Nasimul Jilani. He will speak on approach to a patient with a knee joint. हिमांशु साहब कीजिए बच्चे साहब हमने भी कहीं if you feel कहीं expert comment कहीं आपकी हो तो most welcome. Dr. Nasimul Jilani, please.
Good evening, everybody. I'm really grateful to Dr. Mohammed Hussain, Dr. Pala sir for the gracious word, and I'm really grateful to BMDA for giving me opportunity to present this lecture. So this is a very basic lecture, and I want everybody should see properly, because knee joint pain or osteoarthritis, or patient doesn't see that whether you are an MD or you are a general practice. Patient always approaches you. If patient is not there, his grandmother, mother, somewhere will be there, they will be standing there, money will teach her. So we should know what are the common things we should look. So without wasting much time, I would like to start. So approach to the knee joint is a topic, and I would rename it as examination of the knee joint. So any examination, first we brush up our anatomy. This is the knee. It consists of 2 major bones, that is the tibia and femur, and there is one sesamoid that is called patella. Various ligaments are there. There is medially is the MCL, that is called medial collateral ligament, lateral collateral ligament, menisci, ACL, and PCL. So introduction and condition which we find for the cause of pain or any abnormality in the knee. It can be congenital, like the recurrent dislocation of the patella, patella alta, patella baja. Traumatic, which we will see commonly. Inflammatory conditions like seropositive, seronegative, rheumatoid arthritis, degenerative condition, most common, that is osteoarthritis. One thing to remind, if anything is there, if you are not able to understand, you can stop me, you can interrupt me, and if you feel, we can talk in Hindi or English. So first thing before examination is the history taking. This is very important. The senior consultant says that if you take the history properly, 90% of the diagnosis is done and the 10% remains with the examination. So, the most important part of any orthopedic problem is the history of injury. If there is a history of injury, it is yes. If it is not there, then you should look at the age of the patient. Because if it is more than 50 years, we are looking at something else. So these are the present complaints. That is, first is the pain, which brings patient to the doctor. Second is locking, clicking, giving way, stiffness and loss of range of movement. So understanding these complaints in detail, these complaints are very important. So pain. So pain is a very vague term. We should know what kind of pain it is. It is a throbbing, it is a night pains, it is day pains, where it comes, how it relieves. So just a small detail that after activity if it get pain or if it is at rest, both things are very different. Onset, whether it is gradual onset or acute in onset. And site. Knee as such we say it is a knee joint, but for orthopedic surgeon, knee is a very global term. We have to mark whether it is medially, laterally, anterior, posterior. Then locking versus pseudo-locking. So when there is a locking, patient say कि मारो पग अमुक position में lock થઈ જાય, अटकी જાય. That is the locking, and it roughly says that there is something meniscal injury and the fragment is coming in the joint. While pseudo-locking is because of pain, patient is not moving the leg up to certain range of movement. Then knee gives away. गुजराती में पेशेंट के હું ચાલતા ચાલતા પગ ફરી જાય, બેલેન્સ ના રહે. That signifies there is a ligamentous injury, and there can be multi-ligament injury also. Then stiffness. Stiffness is also a very vague term. In acute condition, because of pain, patient is having stiffness. While in chronic condition, there can be degenerative changes and disused atrophy of the muscles, which can lead to stiffness. Clicking, locking and clicking, there is a very small difference between the two. Clicking means patient કશું કે કડાકો બોલે છે, પછી સારું થઈ જાય છે. પેન થાય છે, કડાકો બોલે and I am fine. So it shows there is something degenerative if age is more than 50. But if suppose patient age is less than 50, then it can be one condition called discoid meniscus. Now loss of range of movement. This is very common, right? For certain degree patient will be having pain, then patient will not have pain. Then patient will not be able to move beyond certain degree, like flexion and extension. So coming to examination, so in orthopedics we don't have auscultation, and percussion is there, but it is only for the few joints. One of them is the PF, that is the patellofemoral joint. So now we have inspection, palpation and spatial test. So I will ask the audience, is it a complete exposure for the knee joint? If anyone can answer. No, this is not a complete exposure. That is the complete exposure. First, you should expose the patient properly before touching the patient, right? And in inspection, what we see that without touching the patient, we should see whether there is a redness is there, any signs of inflammation, swelling is there. These are all the visible things, right? Then, before you examine the patient should be fully relaxed, because as patient has come to you in pain, and as you go and touch, patient is going to dukhav thase. So make him as comfortable as possible. And for orthopedic examination, couch should be in such a way that you can move around all the sides. So you should stand on the side of the knee which you are examining. So down picture is the correct one. Now, various posture in which you should examine, like first in sleeping, then standing and sitting also. So if you can make it out here, the same gentleman is standing in the right side. When he stands on his left leg, it is straight. But the moment he stands on his right side, you can see there is slight bending of the leg. That is called jinuvaram. Yes, bowing of the leg. And this is, we can make out only when weight bearing. So this is my advice to all my colleagues. Whenever you write the X-ray for osteoarthritis, write WB, weight bearing. Weight bearing is very important. Now you should examine in walking, because it will show the dynamic lurch and dynamic increase in valves. Okay. Now deformity. Observe this picture on the right side. Can you find any difference between both the knees of a lady? She is a young lady. Right knee is always quite normal, but on the left side you can see there is some fullness over this portion. Can you make out? And the same thing when you see on the left side, laterally patient standing from the side. So there is a prepatellar fullness. It is called prepatellar bursitis. And there is slight FFD also. There is a flexion is restricted. That is called flip flexion deformity. So all these positions are very important. So now coming to the skeletal type of things. The first picture you see, the first picture, you can see that there is a wasting of muscles. What it shows that there is having the chronic problem. Right? On the opposite side, there is some swelling is there with dilatation of the veins. It shows that some neuroplasm is there. Okay. Then below, this is the most common condition we see in adolescent child. It is Osgood-Schulter's disease. Tibial tuberosity inflammation होता है. And last is the tumor which is arising from the fibula head. This patient reported with the foot drop because common peroneal nerve was affected. Now, telltale signs. This can be like scars, scarring, sinuses occurring, previous surgery scars. This all indicates something which we can diagnose. Now, you can see the difference between thigh circumference on both the sides. Left side there is a wasting of the quadriceps, which says that there is a chronic problem in the knee joint, which is very, very common with chronic osteoarthritis patients. Now, coming to the PF joint, patellofemoral. Now, if there is a effusion, how do we should diagnose? The first test is the Bellotman test, in which we hold the patella and we move the patella on the sidewards. If there is a water waves we can feel, and that is called the Bellotman test. While downward there is a patella tap. If suppose there is a fluid between the patella and femoral condyle, when you tap the patella it will rebound, and that shows the patella tap positive. This is the fluid shift test. Fluid shift test is to diagnose whether there is a prepatellar pouch bursitis or there is a actual knee synovitis or knee effusion. Now, specific point of tenderness, this is the medial part of the knee joint. Various areas which I have marked, it shows that MCL, medial joint line, piece, there is a pes anserinus, popliteal fossa and retroparietal pouch. So coming to examine, we always examine and we always say that there is a ACL. But there is one ligament on the posterior side also which is called PCL, that is the posterior cruciate ligament. There are special tests like anterior drawer test which is for ACL. Second is the posterior drawer test which is for the PCL. Appley's grinding test and Leishman test. One important note over here is when patient comes with acute pain, we should never try to perform all these tests. It will be very painful for them. Now, just compare these two pics. There is a slight posterior sag. आज आपने टीबिया जो ये तो फीमर करता नीचे जाए. It is because of the PCL injury. While on the downside, the peak is normal. It can be because of the quadriceps contraction. This is a modified Leishman test. Test for various menisci tear like McMurray's, Epley's and Square's test. Now, patellofemoral joint. This is the most common cause of pain which we say is anterior knee joint pain, which we see most of the time in our office. And things which we should see in patellofemoral joint is alignment, mediolateral tissue balancing, crepitus and tenderness. So, top picture shows that we are looking for the MPFL. જ્યારે recurrent dislocation થાય ચાલતા ચાલતા ઢાંકણી ફરી જાય એટલે એવી રીતે જોવાનું. This is the patella grinding test in various degrees of flexion where you put the hand or palm over the patella and you push the patella over the femoral condyle and you see the grinding whether it is painful or not. Now, when there is a knee pain, always examine hip, spine, both knees and ankle because referred pain can be there from the spine or hip joint. So your examination is incomplete unless and until you examine spine particularly. So be careful. This is a very important slide. I would like to tell you that when we get the patient asks treatment from us. Yes, I have anu shortcut karo. So when the patient is having severe disease and if they want shortcut, like say कोई minimal invasive कोई injection है वो आपी दो, कि कोई आपने machine से साफ कर दिए, कि कोई massage कर दिए, never agree with the patient, right? Second, be careful when patient comes with the reports. This is very common now. તમને WhatsApp પર MRI કોઈ મોકલે અને કહે કે આનો આર્થ્રોસ્કોપી કરવાનું છે and say sir no, આપણે ઘણી વખતે MRI બીજું અને આર્થ્રોસ્કોપીમાં બીજું જ નીકળે. So never treat the reports of the patient. See patient clinically, you see, evaluate the patient and then you take the decision. Because MRI are reported on the basis of the intensities. Now when to seek specialists? ક્યારે સ્પેશિયાલિસ્ટને આપણે સલાહ કે મદદ લેવી જોઈએ? First, obese patient, when pain is the main complaint and we are not able to correlate it with any examination points, any systemic cause is not known, all blood markers are coming negative, then you should seek the advice for a consultant. When there is a joint space is narrowing on the weight bearing x-rays, when there is a visible deformity, when knee is unstable, severe muscle wasting, because this shows that this is a chronic problem and organic cause. They last psychologically weak patient, right? And last, patient asks for any specific treatment like arthroscopy or the replacement. Thank you for your kind attention. Any questions, please?
આપણે વારમ deformity થઈ જાય braces થી ફેર પડે offloading કરવાની.
As per I will say, madam, no. These are all time buying procedures. But when your lateral joint is good, we can always go for knee preservation surgeries like STO.
એ કઈ એજમાં મેનેજ કરતા માટે મારે the spaces is decreased. Left side, one side, right side solid. Left side, medial side માં there is reduction in space. Suppose if I want to preserve it, there are
various options when varam is not there. Over there varam now and exclusively medial joint is high. So we have one option of UKI, that's the unicondylar knee replacement. That also we can do.
But what is the age when it is recommended?
See, age is not, I don't think age, because some surgeons say that age and weight is the bar. But now we have intra-articular osteotomies also. That is called TCBO, which we used to do with Dr. Samir Sharma. So we have operated around 80 years of age. She is doing good. One knee, there is a TKI, and one knee we have done this correct osteotomy. Results are really, really good. So I particularly what I who માનું છું કે ટેન્ચર કરતા તમારા દાંત સારા. ઓછા શબ્દોમાં કહું છું, ટેન્ચર કરતા દાંત સારા. પલાટી વાળે તમારી વળવાની જ નથી, TKI માં બી નથી. તમે હાઈ ફ્લેક્સ લો કશું બી લો. Because we see patient day in and day out, right? So whenever if you want to, we can preserve your naturally. That is the best gift you can give to your patient. So we are still evolving.
તો થવાનું જ છે ને એને પછી કેવી રીતે?
No, when you correct the axis, loading તમારું થઈ ગયું, સરખું loading કરો. So what happens? એક ડોક્ટર છે સુકુમા કે કાશીનાવા. In Japan there is one tradition. Whenever they get operated and implants are there inside the body, there people always get implant extracted out. ત્યાં કોઈ બી સર્જરી કરે એટલે implant કાઢવાના છે. So that surgeon who has described this TCBO, he has followed for 40 years. એને 80 વર્ષમાં કર્યા છે. જ્યારે implant remove કર્યો ત્યારે he has the photographs of that time. ત્યારે cartilage regenerated થયું છે. Now this is the more upcoming thing જે છે વર્લ્ડમાં આ છે. Knee replacement તો હવે બધા જ કરે છે. It is like a denture of your knee. When you preserve the anatomy, when you preserve your own original knee, that is the best.
What about the role of quadriceps?
Very important.
Quadriceps they થઈ જાય છે ને ત્યારે problem ચાલે છે.
That's why I told you, when the patient has severe wasting, right? When varam is there, તમારે સારા consultant લેવાનું. Sound physiotherapist is very important. They do a very good job. Alignment no madam problem. Asian population માં alignment નો problem આવે. તમારી જ્યારે weight bearing જે line હોય when it shift medial તો તમારો જે અંદરનો જે ની જોઈન્ટ છે medial એના ઉપર more than 85% પ્રેશર આવતું પછી સેકન્ડરી લિગામેન્ટ લેક્સિટી થવા માંડે લર્ચિંગ થવા માંડે and other things add up on that પછી કોમ્પ્લેક્સ
એટલે રોબોટિક્સ નો કોઈ રોલ નથી
કોનો
રોબોટિક્સ જે આ લોકો કરે છે બેસિસ મેં એક વર્ષ પહેલા પણ કંઈ
આપ સાહેબને પૂછીશું
Why do you use periodic imaging? I have plenty of good results.
sir nothing it is not like that nothing can be even what we do sir ने भी खबर है कि we put a fixator ઘણી વખત કેવું હોય કે એક સાથે આખો કરેક્ટ ના કરી શકતા તો આપણે બહાર સ્ટેન્ડ મૂકીએ I have done in few cases and gradually we go on correcting the excess so there are many advancement in it હમણાં તો વચ્ચે મિનિસ્કાઈ રિપ્લેસમેન્ટ કાર્ટિલેજ રિપ્લેસમેન્ટ બધું થતું હતું but they are all orthobiologics કહેવાય it is still in the infant stage we are yet to come up with more ideas but of course corrective osteotomy has a very great role in preventing this.
What about the
It is a very dicey thing. You can you give in patient with having stage 1, stage 2. After stage 2, it is not. My personal experience is there. If patient insist कि भाई तमे आपो तो ज मैं आपू
रोजिप एक्सट्रैक्ट
एक काम करे છે
ग्लूकोजामिन
एक काम करे છે
what period of time I have to give it?
see it is minimum 6 to 9 months અમે કહીએ છીએ પણ પેશન્ટ એટલું લેતા નથી
મિનિમમ 3 મહિના બી બીડી ડોઝ મળે પછી ખ્યાલ આવે
રોજ એક છે ને સ્ટેજ 2 માં હું સામ સ્ટેજ 2 સુધી કામ છે I am personally using it
it has to be given twice a
BD yes and it has a very much on pain જે symptoms નહીં હોય એ તો સારા
so I am using glucosamine and diazepam but it's not acting
પણ તમારો સ્ટેજ એ નહીં હોય અને બીજું undenatured collagen is very useful rejoint UC કરીને આવે છે abutment it is quite costly પહેલા બહુ બધા આવ્યા મેગાફ્લેક્સ ને પાઉચીસ ને બધું આવતું હતું બટ માંથી રોડિંગ ને બધું એટલું થાય ને કે they got failed but one tablet is there rejoint UC that is the only solitary drug which I use બીજા બધા બહુ બધા આવે છે 25 જાતની દવા બોડીમાં હોય but nothing that used this is only one drug that is rejoint UC that undenatured type 2 collagen એમાં એક જ વસ્તુ છે I used to give two different medicines if patient is sincerely one treatment એક આપણે રોઝહિપ વાળું પ્રિપેરેશન અપાય રોઝહિપ વિથ વિટામિન સી સારું રોઝહિપ હશે મેડમ વિટામિન સી હશે એક ગ્લુકોનાઇન with rejoints so રોઝહિપ will take care vitamin C will take care the pain part right and then undenatured collagen જે હશે તે help even હું જે ફ્રેક્ચર્સ હોય છે ને ઇન્ટ્રાઆર્ટિક્યુલર કેમ કે હવે બહુ હાઈ વેલોસિટી ટ્રોમા 25 વર્ષમાં ની જોઈન્ટ આખું ડેમેજ થયું તેની સર્જરી તો કરી after recovery I do start undenatured collagen there are studies ભલે એમાં રિકવરી આવે કે ના પણ પેશન્ટ must be it is quite challenging
ઓપરેટિવ માં કયા એજ છે
સેના માટે
DKI માટે depends on the
see when you get operated right તમારું એનું 20 વર્ષ 15 વર્ષ ફરક જે આજની જે મેક્સિમમ સ્ટડીઝ છે 15 વર્ષ 20 વર્ષની તમારો ની રિપ્લેસમેન્ટ ચાલે then you have to be ready for the replacement that is revision તો હમણાં જેટલા થાય છે એ બધાના 10 વર્ષ પછી બધા રિવિઝન ચાલુ થશે પણ ઓસ્ટિયોટોમીનું કેવું છે કે ઘણી વખતે you may not need replacement after 10 or 15 years બીજો કોઈ ક્વેશ્ચન
hamstring strengthening કરે જ કરવા
that is very good cycling is very good instead of walking you should go for cycling is very good for hamstring quadriceps and it is not a loading when you walk when you jog you are loading your joint but when you are cycle you are not loading your joint even જેને બેક પેન હોય છે ને તમારી એજમાં જેને બેક પેન થાય એને લંબાર કેનાલ સ્ટેનોસિસના લીધે વધારે છે and that will get relieved by flexion right yes so when you go for cycling you get both the things yes. Cycling. They are also not very good. સાયકલિંગ તો કેવું કે આપણે ઘરે કરી શકો. હવે શું છે કે બધા ટ્રેડમિલ રાખતા હોય. મેં કહેતા હું એડવાઇસ કરીશ કે go for cycling.
Treadmill damage is more.
Yes, that's what I
More
said.
damage
If you go for elevation, it is more damaging. Yes, sir.
What type of X-ray would you recommend for a patient coming with joint pain at a GP level?
Weight bearing, knee joint with tibia and femur, so that we can know the axis.
Weight bearing.
Yes, weight bearing. એને કહેવાનું લોંગ શોટ લેવાનું કે આપણાને એની એલાઇનમેન્ટ કહો. ની જોઈન્ટમાં બીજું કશું જોવાનું નથી. આટલું ની જોઈન્ટ બતાવે એમાં કશું ખબર નથી. એટલે હું મારી ત્યાં તો લેટરલ બી ઊભા રાખીને રહું છું વેટ બેરિંગ. બીકોઝ વેટ બેરિંગમાં તમારી એક્સેસ ખબર પડે. તમારી એક્સેસ વેટ બેરિંગમાં ત્યારે જ ખબર પડે કે હાઉ મચ ઇઝ ધેર. એન્ડ યુ કેન સી ડેફિનેટલી તમે પોતાને જાતના અરીસામાં જોશો ને તો તમને ખબર પડશે હાઉ મચ ડિફરન્સ ઇઝ ધેર ઓન બોથ થિંગ્સ. ઓકે. Yes, over. So it is a very good thing that we have one subject with us. One subject with us. અવાજ આવે છે બધાને? So as I said, આપણે પેશન્ટ ને કમ્ફર્ટેબલ થવું જોઈએ. But here I don't think that we can. So suppose I am examining the left. If anyone interested, they can come over. જેને જોવું હોય બધા અહીંયા આવી. So always
Examination is going on. જે લોકોને ઇન્ટરેસ્ટ આગળ જોઈ શકે છે. Our next CME will be on 31st of this month with Adigra Hospital. Dr. Hiren Parikh and vascular surgeon Dr. Vijay Thakur will be the speaker. Inshallah, with the Zydus Hospital. So thank you once again. બધાએ આવો હેક્ટિક ઓપીડીમાંથી ટાઈમ કાઢીને વરસાદના ટાઈમમાં અહીં આવ્યા ને જઝાકલ્લા. હું ગની સાહેબ ને હનીફભાઈ તરફથી બી બધાને વન્સ અગેન બધાનો આભાર માનું છું. થેન્ક યુ. એન્ડ અગેન આપણે ઇન્શાલ્લાહ નેક્સ્ટ સીએમમાં મળીશું. ગની સાહેબને બી કહીશું કે ભાઈ આ જ રીતે ટાઈટ કાઢી દે અમારી દરેક સીએમાં તમે પધારો. થેન્ક યુ. જઝાકલ્લા.
Shukriya, Jazakallah. Thank you, Muhammad Hussain sir, for giving us the opportunity to interact with the BMDA. A nice lecture. Dr. Merchant sir, thank you very much sir.
So thank you all of you for giving me support. Thank you Bala sir once again for the gracious words. Thank you BMD. Allah Hafiz.
Some people are having picture, very few people are.
We'll share both the PPT in the group, inshallah.